Hi everybody, I'm Jen Fredenberg and I did Sulcus Vocalis. So just to give you a description, when I was looking at the pictures, the first thing that struck me was that you don't have this nice white pearly uh, color that you do in the normal vocal folds. So, oh, can you see it in the, oh, how can I do this? Everything is opposite. Oh, the light is not good. But anyway, these are gray. Oh, there we go. Okay, so if this is your epiglottis, this is your tongue down here, right? These are your vocal folds. And the color's not so great, I'm sorry. But these are really gray. They're not that nice white. And the surrounding tissues, they seemed bloodshot to me. So lots of red and blotchy. So there's that, okay? The other thing about this, when I looked at the picture, especially the black and white picture, at first I was like, there's nothing wrong. Because when you look at the edge, right, you don't see any bumps. It looks smooth. You can see all the five, I can't really see it from this, but I have 5 layers of ribbon here. But when you look at the medial surface, right, there's a groove. You can see my finger coming through, right? So that's the sulcus. And the length of that can vary, and also the depth of that can vary. And it can be so varied that it can be as deep as the final layer, which is your thyroarytenoid muscle. If it's very long and very deep, it can actually cut your vocal fold in half. Now, here's another really great image. I love this. And I also have a PowerPoint. So if you want this image, you can get this off the PowerPoint. So there are 2 types of the groove or the sulcus. Okay, so the first type, so if we have our 5 layers of our vocal folds, right, those nice oscillating vocal folds, the first 2 layers make up the cover. All right, so your first type is just going to, type 2, is just going to affect the cover. But as I had mentioned earlier, if you have a really deep sulcus, it's going to go all the way to that deep layer and then into the muscle. Okay, so there's that. I don't know if you can see that. All right, so what's the etiology? They don't know. They're totally uncertain. They don't know if it's overuse, misuse, abuse. They don't know if it's congenital. It seemed like they were leaning towards congenital, but they weren't really quite sure. They don't know if it's developmental. They don't know if it's traumatic. They don't know if it's like a reoccurring chronic inflammatory thing that happens. So there's that. Also, it's really rare. And I found it especially interesting that it's more rare in the United States and in Europe and more prevalent in Japan. So go figure. Okay, so perceptual findings. You find a rough, gravelly quality to the voice and also a breathiness because those vocal folds aren't closing all the way, all right? Abnormal vibratory behavior and also a higher pitch than normal. So, acoustic findings. Jitter and shimmer are within normal limits. Also, the noise to harmonic ratio is also within normal limits. Maximum phonation time, it's slightly shorter, so that sustained ah doesn't last as long. And the ranges in the glide, you know, when you go from low to high, high to low, they're also shorter too. So someone who's dealing with sulcus vocalis is not going to have the octave range as, say, we saw when Dr. Hemmerich did it. The aerodynamic findings. So the airflow is slightly higher than normal. And interestingly enough, you know, you can have a unilateral, I'm sorry you can't see it, oh, maybe over here. You can have a unilateral sulcus or groove, or you can have them in both folds, so a bilateral, both sides, right? So the airflow, it's going to make a difference if you have just one or if you have both, right? The mean flow and peak flow are going to be greater than expected. The leakage flow is going to be within normal limits and increased perturbation. The stroboscopy findings, again, we're going to have an incomplete glottal closure, slightly decreased amplitude, and slightly decreased mucosal wave. And again, it makes sense that that nice mucosal wave that we saw in the normal findings, or what we've been viewing in cases with normal vocal folds, we're not going to find that when you've got this groove or this sulcus. But if you only have one groove, right, the unaffected vocal fold is going to have their mucosal wave will just be just fine. So there's that. The pathophysiology, the sulcus is found, I already mentioned this, but the sulcus is found in the cover usually. So that's your first two layers. That's that squamous tissue, the epithelium, and this superficial layer of the lamina propria. Okay, treatment. Voice therapy, you can do voice therapy, although it doesn't cure the anatomy of what the problem, right? So surgery is recommended. It will increase the loudness of your voice. It takes about 3 to 4 months to recover from that kind of surgery. And that's it. I have a PowerPoint. It has, like I mentioned before, it has this image. Whoops, everything's backwards. And it has some pictures. So you can view those if you're interested in that, or if you just want to have a printout, that's fine. And that's it. Okay, have a great day.